for the meeting, and I will chair this board meeting in public. I've got some welcomes and apologies to cover. So welcome to Fiona. This is your first meeting as a non-exec director, so you're very welcome. Thank you. Welcome to Obi, who's joining us as our improvement director. Welcome to your first board meeting in public.
Morning. Afternoon, Ron.
I've lost your sound, Sarah.
Oh, excellent. Okay. Helen, can you hear?
Yep, I can hear you fine.
Obi, can you hear me? Yeah. Tim, can you hear me now?
A bit better, but not great.
Okay. I'll
That's
speak
better.
up.
That's better. That's better. I think it's just where the owl's facing, I guess.
Okay. So Tammy, very welcome as our designated finance officer. Thank you for joining us. And then Oliver's portfolio has slightly changed. With us in his new role as Director of Partnerships, Performance and Improvement. And Sean, your role has slightly changed, and you join us now as the Interim Director of Operations, and you want to just explain what that covers?
Yes, thanks, Sarah. So I'm Sean Stacey, and as been suggested, I'm now the Interim Director of Operations, and I cover all of Manx Care's operations. All areas from ambulance, community, primary care, social care, mental health services, hospital services. All of those areas are now directly reporting through me for their operational. Clearly, my role is to make sure our business runs itself really well. But I do that in conjunction with my two partners in crime, Sheila as the chief nurse and Chris as the medical director. So we are running the organisation in that triumvirate way.
Thank you very much. So we have Tim, Helen, and Obi online, as we've already discovered, and apologies, as I've said, from Wendy, but also from Nigel Wood, Sandra Cardwell, and Jackie Lawless. Have I missed anybody, Elaine? That's good. Excellent. In our pack, we have the director's the director's declarations of interest. Is there anything that needs to be added on in light of today's agenda? No. Thank you. Minutes from the last meeting held in public are in our pack. If I go through those page by page for accuracy, so page 6 in your pack, 7, 8, 9, 10, 11, there was a lot discussed, 12, 13, 14. Okay, excellent. So we can approve those as an accurate reflection of the meeting. Thank you, Elaine. Matters arising and a review of the action log. There is one item on the action log which is not due to be closed until later this year. That's correct. So nothing to report. No. Great. Does anybody have any items of any other business that they would like me to consider at the end of the meeting? No? Excellent. So we are joined by some of our colleagues from therapies. I would like you to introduce yourselves, if that's okay. And do you know everybody around the table? If not, we can just do some quick introductions.
Sure, so I don't think we know everybody.
Okay. Well, why don't you introduce yourselves and then we'll do the same.
Yeah. So I'm Kelly Golland. I'm one half of the head of therapies in Manx. I'm Frances Butler. I'm the other half of head of therapies, and I'm also a physio, and I work in paediatrics for part of the week when I'm not doing head of therapies work.
So I'm Charlotte Cairns. I'm the service manager of therapies.
You're very welcome. I know this is a formal meeting, but we do hope that we can have a conversation with you. I know you've got some things to present to us to start with, but and I'll just ask colleagues to introduce themselves. So Fiona.
Fiona Hatton, 4 weeks in. So yeah, moved back to the Isle of Man 3 years ago after 20 years overseas. So very happy to be part of Manx.
Hello, good afternoon. My name's Charlie Orton. I'm one of the non-executive directors for Manx Care. We've met before, I've seen you present before, and I've been on the board for 2 years now, and I run a national charity in the UK for addiction recovery support. Welcome.
Afternoon, you know me, Chris Lockport, Exec Director for Yasson.
You all definitely know me, Sheila.
And I know I've some of you, but I don't know if I know all of you, but it's really nice to meet you. And I'm Sarah and I'm the Vice Chair.
And you, Manny.
You know me.
This side of the room is really And then behind you, we have additional colleagues. Tim.
Hello, welcome. I'm Tim Bishop, a non-executive director.
Helen, can you hear me?
I can, yeah. Afternoon, colleagues. Nice to see you.
Obi.
Good afternoon. My name is Obi Hassan. I'm the new boy just joined on Monday. I'm the Financial Improvement Director. I have a long background in the NHS, but also island experience, most recently in Jersey. And I'm really looking forward to meeting. I know some of you already. I worked with Sean before. So I'll look really forward to working with you. Thank you.
Thank you. So over to you.
Thank you very much. So apologies, I'm at my awkward age of glasses on, I have glasses on. So we were invited to speak today following a therapies day that we held back in May, and it was an annual review really to celebrate our successes and the things that we're doing well and the things that we're trying to push forward into the coming years. So this was our second annual event, and the first one was the year before. So we've included our presentation for the day in the pack. So we won't talk through all of that because that is considerably longer than 10 minutes, but we just wanted to pull out some of the highlights really. So for us, the operating plan highlights the importance of seeing the patient or the person at the right time by the right person. And within therapies, we have been progressing through various different areas, and especially in relation to primary care at scale or home first. So that push to have stuff out of the hospital. So so myself, Francis and Charlotte will talk about a few of the different highlights. One of our main highlights is the first contact physiotherapists, which are now working in the GP practices. So at the moment we're in 7 GP practices, but by autumn, hopefully by September, we would expect to be in all of the GP practices on the island. We're currently recruiting just for the final 2 posts, so we were shortlisting this morning, so that's really exciting. So it means anyone with an MSK problem, so musculoskeletal problem, instead of seeing a GP, has the opportunity to see a physiotherapist first. About 30% of GP appointments relate to MSK problems. So whilst we wouldn't pick up all 30%, it's a really good shift away, and it means the GPs can do the work that they can do, and physiotherapists who are experts in the area can do the things that they do. So it's working well. We're already seeing a reduction in referrals onto secondary care, a reduction in pain meds, and so the outcomes that we're looking for, we're already beginning to demonstrate, and hopefully as the time goes on, we'll do that even more. One of our other areas as well, which we've reopened since COVID, is just within our self-referral physiotherapy. So the ability for anyone on the island to self-refer, again, if they've got a musculoskeletal problem. We've got sites at CHC, in Douglas, we've got sites up in Ramsey, and we've got sites down south in Tyrone. So every port of call. At the moment, the West, we're not in there yet, but the West generally either goes up to Ramsey so we're definitely reaching people closer to their homes, which is fab. And then the final one area that I'm going to talk about is our work within the Frailty and Falls. It's a bigger piece of work, which is great because it crosses various directorates and care groups. But we've been working with fallers, so people that typically present to A&E but don't need to be admitted. And historically what happened was these people were just sent home again. Well, you're doing okay. But actually there was no analysis into why have you fallen, what's gone on, can we prevent further falls. So with the falls practitioner and the frailty practitioners have been leading on it, but now we've got clinics, so A&E or GPs can refer in for patients that have had a non-injurious fall. And then it's an MDT approach where we look at the reasons for the fall. So we're finding about 50% of people haven't been started in osteoporosis meds. There's the simple trips, slips, those sorts of things, environmental concerns, medication where they're over, on about 10 different medications, and they haven't had a recent medication review. So falls are so multifactorial that it's a really good so it's a one-stop shop, and then we signpost mostly back to the GP at the moment. But it's again, we would hope that it is leading the way in preventative stuff. So it's going to stop those fractured hips, which we know have massive detrimental cost for the NHS and cost to the patient is huge. So that's my three that I was going to highlight. So,
Thank you. Yeah. So one other area we're expanding, which aligns quite closely with the first contact physios and again care close to home, is non-medical prescribing. So that's where obviously some of our therapists who are working at the top of their grade do the non-medical prescribing courses and they are then able to help with some prescribing that may prevent further deterioration or further problems. So for example, a podiatrist with a non-medical prescribing role could prescribe a course of antibiotics for somebody who's showing signs of infection, and that might very well help to prevent an A&E visit or another GP visit. And we started that, and we are seeing more and more of our practitioners at the right level being interested in developing that in themselves. So we're looking at other of our AHP professions. So we've got dietetics in our bag. And we've recently recruited an oncology dietitian in partnership with Macmillan Funding. So we've got 2 years of funding from Macmillan to help with those patients who have got GI, head and neck cancers. And that's a really important development for our small team of dietitians. We've been trying to get that over the line for a while. And from a speech and language therapy point of view, we have had a business case out for a while for a service for assistive and augmentative communication and environmental controls. So what that means is people who are unable to speak or make their wishes known in any particular way, to be able to have help with that. So it can range from very simple help, such as a child using a picture board at school called PECS, where they can indicate, if they're non-verbal, where they can indicate what they need, right up to really high-tech solutions for patients who have paralysis or who have limited movement. So it's a wide service, but we don't really have one. But we had a successful charity bid for mild to moderate AAC. So we have Henry Greenlow kindly gave us some funds to purchase iPads and specific apps which we can use with people, both adults and children. So we're just getting those all up and running. It's been a bit easier for the adults because we've had a little bit less in terms of app safeguarding for adults as opposed to children. But that's been a real step forward. And we are then going to look at what we need from that for those more complex patients where you might have to have, for example, the communication device and the ability to operate that from, say, a wheelchair or from specialised seating, those sorts of things. So we've started on that journey, and we hope to really build on that going forward. So those are the bits that I wanted to highlight, and I think over to Charlotte.
So as well as all the kind of achievements that we've discussed today and the ones that were discussed in May as well in the slide deck, we're also very proud of the culture, the commitment, the expertise and the professionalism that we have in therapies. This has been recognised on a number of platforms in recent months. For example, the Manx Care Awards, where we were very well represented, and Frances actually won an award, which was fantastic. But as well as that, that's really helped our recruitment and retention. So as an example, we've had a number of locums who started as locums, but because they've really enjoyed working in therapies and they've recognised, you know, what a great bunch we are, and they've actually decided to stay. So that's so great from a financial perspective as well, so much cheaper and substantive. So as well as that, we always recognise that there is room to improve, and we are always looking at ways that we can kind of future-proof the professions as well. So we've done quite a lot of work with universities in the UK about potentially offering remote training for people who don't want to leave the island, because as an example, OT is an area that we are particularly short of, and that is one of the courses that we're hoping to be able to offer, if not this year, possibly next year, for a limited number of places. So given the kind of difficulties that the OT shortages kind of obstructed our abilities to meet demands over the recent months, that would be a welcome addition, if not right away in future years when we get people trained up. So yeah, thank you for listening. Has anyone got any questions for us?
Thank you. Thank you. That's really interesting. Do any colleagues in the room or online have any questions? Chris?
I'd just like to make some observations actually, and I have to say, it never tires me listening to this Dan talking because of the enthusiasm. But I'd reflect upon 25 years really in general practice and the things that I'm most proud of, and they would involve bringing in 3 roles in primary care, none of which were medical. I think that's really important. First is in terms of navigation and some professionals actually who understand social prescribing, and you sort of touched upon that. The second would be upon first contact, mental health, CPN type roles, and we've not talked about that today, but what we have talked about is the third role, which is first contact physio, which completely revolutionised primary care from the perspective of GPs I worked with and for patients, and it brought about such a difference in outcomes and satisfaction, more than any other roles that I could think of. The risk that you have in doing that, beyond just persuading the public that it's the right thing to do, and you only have to have one contact before you're convinced about that, by the way. So yeah, we need to stick with that. But the longer term risk you have is that you then train all of your professionals up to extended scope practice, and you get left then with a little bit of a gap. So the third point that you brought in terms of the importance of growing your own is something we've got to make sure we don't lose, so that we're continuing then to create a sort of funnel of professionals to go into these roles, because they will grow.
Now, Tim.
Thank you very much. It's a really great presentation. Thank you very much for your time, and thank you for all you do. Really good to hear about out-of-hospital services and community services. Really good to hear about services that prevent people needing to come into A&E or into hospital. Really good to hear about services that hopefully prevent some people having to use outpatients and to get direct access to some of the therapies which assist them, and indeed from that being given the tools themselves in terms of exercises, etc., to manage MSK. Also, as we know, MSK is one of the key elements in terms of sickness and people's employment, and so really good for the whole community, the whole island, if we keep people well, so they can continue to be productive either in employment or in their retirement or whatever. So really important. And the other thing, just to touch on, which has always seemed really important to me, having in the past had older family members who have slipped or fallen in hospital. Really important in terms of when people come to hospital, making that visit, that admission as safe as possible, so that we don't add to people's list of issues when they come into hospital. So really, really good to hear about work around slips, trips and falls and making people safe in hospital. So just thank you very much. Very helpful, very interesting. And I think a really key service in out of hospital, but also in making hospitals safe as well. Thank you.
Thanks, Kim. Sheila and then Charlie.
Thanks, Chairman. And just huge thank you to all of you. And just building what everybody else says. It is the future. What you're doing is absolutely the future. It's what we want, not just for a one-year operational plan. This is absolutely what's going to be moving forward in the next decade as we get advanced care practitioners, allied health professionals, nurses, etc., to be able to be out in the community looking after our people out in the community. And you demonstrate that beautifully. But the one thing I would like to say, Chair, is leadership matters, and these are our leaders. They without a shadow of a doubt, need very little support and just naturally are very future-proofing all of the time and caring for the people in their teams. And I'm just delighted, and I know that you've been able to secure staff because people want to follow you, and people want to stay here because they feel safe and they feel they've got a really good future professionally as well. So you're an absolute credit, and thank you. Thanks, Sheila. Sally. Thank you, and I echo everything Sheila has just said. So what I'm starting to hear around the board table is everything is crystallising down to getting it right first time for our patients, isn't it? The GIRF model, care closer to home. I'm hearing about patient-initiated follow-up, and you've just mentioned self-referral. And I'm a great believer as well in mutual aid groups, so people with the same problems helping and talking to each other in that social supportive capacity. What would be really great at some point is to be able to see kind of a view from the bridge of the operating plan of all these specific examples of how we're empowering people to make decisions for themselves, and to be able to demonstrate that to the residents of the island, I think would be quite a powerful piece for us to undertake with respect to delivery of the operating plans. And this is what we mean by GIRF, but this is actually how we're doing it, the practical real life examples, because I do believe that empowering people to look after themselves better, but help to work in consort with you to make the right decisions for their treatment plan and their follow-up, and whatever other support they have as well, is absolutely the right thing to do. But it would be great to see this from pulled out from the operating plan as one piece, so we can see this list of practical things that we're doing to shift away from hospital care and into a more community-based model. So thank you so much for what you're doing. It's great to hear.
Me about comments or questions. So from my perspective, it was absolutely great to hear that people are wanting to come and work with us in substantive roles. Not only does that speak, I think, to the culture that you talked about, Charlotte, and people wanting to join the team, but obviously one of the things that we spent a lot of time looking at is the money, and knowing that someone, you know, whilst that might mean that the numbers have gone up in a team, but actually the numbers have gone down in a team, and that's really, really good to hear. And I'm a huge fan of that. And then just really pleased to hear about the Grow Your Own. Obviously, been a lot of work done in maternity about that, and we've seen the fruits of, I was going to say the fruits of our labour, unintended, I suppose. But to see that and give people on the island the opportunity to stay and train. You know, it's good for us, but it's also good for the island. So thank you so much for all that you're doing. In another world, I tell you about my enormous passion for physiotherapy, and having had a series of issues. I broke my back 2 years ago, and you know, the physio was the thing that kept me well. So to the point about, you know, getting it right first time, keeping people closer to home. Yes, I needed intervention in the acute moment, but it was the physio that has kept me well and out of hospital. So thank you to all of your colleagues. Please do pass our thanks back to every bit of the therapy profession because it's incredibly valuable, as I hope you've heard us say today. Is there anything you'd like to ask of us, or anything you wanted to say that you haven't said yet?
No, I guess some of the things that we are striving for, I guess we have struggled particularly with that, the AAC, EC kind of business case that sort of went into the ether and never really progressed. I think sometimes I feel like we definitely could do more for somebody who, say, has an advanced neurological condition or has an accident, has a head injury. These are the people where we need funding and time for our employees, for the appropriate staff, so our OTs and our SLTs, to be able to at least provide that higher level AAC. I mean, I think, AI is going to make a big difference to it. But there are still people there are still inequities where somebody might have had a charity done something for them. And there is still a need for staff training and a little bit more staff time. So it's one of those things where, do we decide to commission specialist assessments from a specialist centre like ACE and then learn to support them here, which is often how we have to go across all our professions, really, where there's a specific need, but the patient lives here and it's 3.5 hours by sea or an hour by plane. So maybe having the assessment first of all, and the specialists do that bit, and then maybe having some more training or some more professional time to be able to support things on island, because we can learn that stuff and we can help with that stuff. We just haven't got. It's possibly a thing where the economy of scale matters. If we have 4 people a year who need a really high level assessment, then surely getting an expert service to do that, and then for us to support that, would be the right thing to do. But there are a number of people, I think, who we could help, and a number of patients in our community that need that.
Yeah, thank you. Teresa?
I was just going to come back on, I think the professionalism and leadership of this service is to be commended. You have worked so incredibly hard, and the service is in a very different place than where it was 4 years ago, and I think you've been the first to acknowledge that. The service has real identity, clarity of roles, and a real place within the organisation. I think if we're looking sort of 5-10 years hence, what would be incredibly helpful for, I think, this board to understand is, what is the potential as we start to develop the clinical strategy for this organisation? What is the potential for therapies? If we think about working at top of licence, where you can have the most impact, but what we have to be able to do to have it sort of reflected in our mandate going forward is to understand what the impact of that will be. So what does this mean? And I know that's a big ask, but I think if we could get into that space of your team, the level of stability and vision you have to describe what that future could look like and what the benefits to the island population could be, then that will help us mean that we have the right discussions when we start to discuss the mandate going forward. And when we haven't, we've played to your strengths as a team, which has demonstrated you have great stability, great professionalism, and clear vision about what your services could look like with that additional investment.
Yeah,
that would be a challenge to you.
Yeah,
and the challenge. Great. Oh, thank you so much. It's lovely to see you. And thanks for sharing such inspirational work. Thank you very much. Thank you. Thank you for the opportunity. Thank you. Thank you. Bye-bye. So I'm going to move us to the board assurance framework. Paul, welcome to the board. Thanks for joining us. Are you going to talk this through, or is Teresa going to?
No, I'm going to hand directly over to Paul and Elaine, because effectively they led this process. And
over to you, Paul.
Thank you. Thank you very much for inviting me today, Chair, to go through the Board Assurance Framework. I'm absolutely delighted that we're now moving into a position where it's actually clear on a page. To provide context, the Board Assurance Framework, we have our own nuance, whereas in the UK, it's very much, these are our strategic objectives. On Ireland, we have our legislation, then we have our mandate, our operating plan deliverables, and it sits under the umbrella of 4 strategic objectives. What I've done is I've mapped every operating plan deliverable to the mandate and then put them under their primary strategic objectives. These have been split, so each subcommittee of the board will have a BAF sheet similar to that. That will have execs who are accountable to the board, but added to that is senior responsible officers who are responsible for delivery. These are the people that will be pushing those operating plan deliverables. They'll be the ones that provide the updates. What it does do, it puts on a page, though I may have to go on 2 pages because there's a lot of deliverables under that, where it's rank rated, where at a glance, the board or anybody can look at it and triangulate where we got obstructions or where can't we deliver to allow that extra focus. Accompanying each BAF sheet will be those extreme risks on their separate template, which again allows the board to actually look into. We're just finalising now, myself and Elaine. The other 3 sheets, well, they're just on paper, they're going to go out to the execs. And then in September will be the premiere of the new revised Board Assurance Framework reporting to the board.
Thank you.
You're welcome.
We had the opportunity to get very excited about this in QSE. So, Tim, I don't know if there's anything you want to say about the detail that we were able to look at this point.
I think just to say that having this clear structure and this clear process really looks like it's going to be helpful, and it means that we'll be using this to drive our business, and I think that's a first for us, rather than having a fairly what might have been referred to as a mundane sheet that we used to look at and comment on. I think this is real and live, so really welcome it. Really great to see, and to thank all those involved in all the work that they've done on it.
Thank you. Any other comments? Sheila?
Just to say a huge thank you really to QSE, Quality and Safety Committee, to QSC, for being guinea pigs really. Because we've gone back and forth a few times, and just to say, Chair, supporting each of our committees to the board, QSE also looked at terms of reference and cycle of business and whatnot, but it all interrelates. We can't do the rest without the Board Assurance Framework.
Cool. Thank you so much. Thank you, Paul. Thank you, Elaine. I think, as I said at the QSE meeting, these things can be really boring, and this is not. This is really easy to read, easy to understand, gives you, very clear indicators of what we should be worried about, what we can, how we can regulate, I suppose, those risks and know which ones are being dealt with and those that need more attention. So it's fantastic. Well done.
Thank you. I'm very, very proud of it. Thanks to Elaine. But I understand the board's extremely busy and the execs, and sometimes they get information overload, and that's what the Excel spreadsheet was. It was information overload. This pulls it out, puts it on a page, and along with the assurance reporting will reflect that.
And, I think that's a really important point to make is, often organisations, when things go really badly wrong, it's because there was far too much information and people did not understand what they were being shown. So I think this gives us really great clarity on what to focus on. And as I say, those things that at the moment don't need that focus. So, from a particularly this one that we're looking at now, from a kind of patient safety and quality perspective, could be more important. So
Thank you, Chair. If I may just add one thing, this is an example,
Yeah.
so please don't be alarmed about reds or ambers. This was just put together completely to provide an example. What will go through into September is the actual
in the
assurance report.
premiere.
In the Premier, it's the thing. And I'm more than happy to come back and present that if you wish.
I think that would be appropriate. Yeah. Thank you.
Thank you so much.
Thanks very much.
Thank you.
Thank you.
Yeah, it's a movement, it's great on there.
I'm obviously putting some sort of red carpet.
I'll bring an Oscar.
So in Wendy's absence, I'm grateful to Teresa for providing me with some updates to provide under the chair's report. So it is indeed the International Day of Paramedic today, and on this island we have an ambulance service that we can be incredibly proud of. Again, as I would reflect from the presentations that we've been given by Will, led by an inspiring and inspirational leader who's worked really hard to create an excellent culture. And I think a couple of us are going to try and go and thank some of our paramedics on this important day for them. Last Friday, the neonatal unit here celebrated its 10th anniversary, and I was absolutely delighted to see that the very first baby that was born there came back to cut the cake.
Aww.
So, yeah, Evie Rose Hill. So what a wonderful, sometimes I think when babies or individuals are in that very precarious state, it's such a lovely thing for the staff as well as for the family to be able to come back and show how well she's doing. So that was lovely. Tynwald Day, as Helen has already mentioned, was yesterday, and thank you very much to all those members of our staff who continued to work whilst many people were off enjoying themselves. And if you are on LinkedIn, there's an absolutely brilliant piece by the ex-chair of the IOD on the island, Jennifer Horton, I think her name is, explaining why it's so important, the significance of it. So I feel like I've now learned a lot. And then finally, just to thank the exec team who were out and about at the government roadshows recently with an opportunity to gather feedback from the public. That is really important for us to be part of that, and also for the public to see us being part of those visible roadshows. And I understand that there were a number of questions, Teresa, and those are going through the MCALS system as we speak. Does anyone have any questions? Thank you. Teresa.
Yeah, thank you, Chair. So my report is sort of the Chief Executive's Horizon scan, but with contributions from the wider exec. And in this particular, nothing really to draw attention to, but I do want to sort of celebrate some real successes, and I think they're really important. Around our strategic priorities around quality and safety. Also, that issue that we talked about with therapies presentation around retaining our workforce, getting up our workforce. And some real success there as well as with our strategic partnerships. So the Oncology Day Unit and the Macmillan Cancer Information Centre, both retaining their prestigious Macmillan Quality Environment mark. So the Oncology Day Unit receiving the highest. And this is due to the dedication and commitment of our staff, but also importantly due to the support that we receive from our local charities, who really help us to provide the best quality environment for our patients to receive their care. And I think this builds on the very successful Clatterbridge at Nobles model that we already have. The gynae ambulatory unit as well also opened, and again this is part of a wider piece of work of our ward reconfiguration programme, which is starting to redefine how we use some of our wards, get them refurbished and fit for purpose, but also moving people into more outpatient settings where that's appropriate to do so. And again,
some of this is aided by our local charities. It wouldn't be right if we go into the Southern 100 not to reflect on a very successful TT for Manx Care, where the very extensive planning that we undertake every year really paid off. My report just covers some of the numbers behind the activity that goes on. As I say, we started Southern 100 yesterday, and we've got the Grand Prix at the end of August. Integrated mental health, I just thought it was worth really recognising some of the impact that we've had from the transformation funding that came through at the back end of last year. So this was additional money received by Manx Care on top of our baseline budget to specifically respond to the waiting lists in our CAN service and to allow us to move to that new model of care called Thrive, which we signed up to a number of years ago, which really starts to place a stronger focus on our work into schools, a single point of access and more early intervention and self-help. So working in conjunction with our Listen and You Talk service launched in May. The work on the waiting list started at the end of the last calendar year, and as you can see, our waiting list has halved in that time. So some very positive work. We've also talked about the impact of the mental health first contact practitioner, which is really, really positive, has been received so incredibly well by GPs, and we absolutely want to roll that out. Our other commitment is around really making sure we've got a sustainable workforce for the organisation, and there has been substantial efforts over the last 4 years to recruit substantively and address the very high vacancy factor that the organisation had 4 years ago. So 22% was what was being recorded and was consistently recorded for probably the first 2 years of Manx Care. We now know that vacancy factor is between 10 and 12%, depending on which team and which service. And I think that's really, really positive. And it usually means reduced costs in those areas because substantive staff are costing less than the bank or agency staff that would have to be deployed in order to cover those services. Added to that, a real strong commitment for on-island training, both at pre-registration and post-registration, and my report talks to that. Led by the Director of Nursing and Allied Health Professionals, we have worked to commit that the 24 student nurses who graduate from Kildare this summer will all be allocated roles within Manx Care for those that want to, and most do actually. All of them do want to come and join us. So again, I think that's really, really positive. It means we're still working through the numbers, but it does mean that our vacancy rate for Band 5 registered nurses is incredibly low. And we will confirm that. So I think it's always nice to recognise the achievements, and there are so many of them across the organisation. The full horizon scan does signal all of those, both across our operational services, but also our corporate services, and that ongoing commitment to connect with the public through our engagement teams, the Council of Ministers roadshows, the In Your Shoes sessions, which are incredibly helpful to understanding how people using our services shape them moving forward. And we've three of us and the other execs will have their opportunity, had our chance on the man in line. Which was a joy. Was a joy, yes. Thank you. Happy to take any questions on my report.
Any questions or comments for Teresa?
Really just to support around growing our own care and the importance of that. And when a student nurse comes into our establishment, which is for 3 years, we have made a pledge that they have a job with us from the minute they start. They've had their interview. Once, if they pass all their placements and all their academia, they most definitely have a place with us going forward. So no interviews at the end to say whether you can have a job or not. That's not the case. We've already recruited them, and that's been really, really helpful. And the quality of the education being provided on island for our student nurses is quite incredible. Both for you know, physical health and mental health students, but I can see over the years it's been a really great success. And as Chief Executive said, the Band 5 vacancies are very low.
Yeah, excellent. Helen.
Just a quick update based on this morning's run through of the placement for graduated nurses this year. So far, only one student has let us know that she won't be available to work in Manx care post-graduation. Her husband has received a really great opportunity, a great offer to go and work in South Africa. And so they're moving over to South Africa as a whole family for the next couple of years. But even still, they have every intention of coming back home. So we're going to keep communication channels open with her, wish her the very best while she's in South Africa, and look forward to her coming back to us when that secondment place is finished.
Thanks, Helen. Just a couple of things for me. Really good to see the changing places and facility open on the ground floor. I know that's something we've talked about for a while. I think it's so important to people's independence, dignity, their ability to be able to access our services and know that they can do that with respect and dignity. So really pleased to hear that. As a communications professional, I'm very embarrassed to say I have literally no idea what Loop is as a communications channel.
Assisted hearing. It's the devices.
Oh, well, I thought that it was, and then I thought, no, it must be much more sophisticated than that. It was a brand new kind of online platform. Okay, good. And then delighted, and we did talk about this in People Committee, to hear about the development of Manx Care's own website, which I think will hopefully help so much in terms of some of the things we've already talked about, actually, in terms of accessing services or knowing where to access services and people being able to get help and advice in a much more easy way. So really good to hear everything that's going on, Teresa. Thank you so much. Oh, and the final thing was just the point on your section about the TT, about the cost pressure. And really, you know, what a figure to see that 55,000 people came to visit, you know, on an island that has 78,000 people. That's an extraordinary additional extra number of people visiting. And yet, if I'm interpreting your report correctly, we don't have any additional money, and we run that as a cost pressure. Is that correct?
Yeah, that's correct. I mean, Oliver leads on this, so perhaps Oliver, you want to give an update on that.
Well, yeah, you're right. We do have a financial allocation, so we do have a motorsport budget, but we allocated the money from core funds. We've never been given any specific funding for the event. Sitting on the National Motorsport Committee, that myself and Teresa, you know, we're not alone in being in this situation. There's a number of government departments that have huge pressures during TT, so infrastructure, the road network in particular, the police have a huge increase in police officers on the streets during TT, and it is all drawn from core budgets. So I know that this is something that as a collective group of execs from different departments on that committee need to discuss with the Treasury and the House of Ministers in terms of, you know, the TT is a world-class event. It is you know, it's now, thanks to TT Live, it's been to every corner of the world. So it's becoming as famous as F1 and other. And, you know, we need to have the financial and the governance framework behind it to support that level of event. So, but we're really keen to work with the, wider government stakeholders to try and achieve that, so that we don't, we can make sure that we can deliver a safe event without thinking about the funding implications of it. So that's a work in progress.
Thank you. Charlie and Angela.
It's a question and a very naive one, forgive me, Oliver, but given the amount of money that is in the motorsport industry, are there ever any opportunities for money to come from the industry to acknowledge the cost pressure, the medical and healthcare cost pressures of what the TC brings to the island, and whether there are ever any avenues to explore within the motorsport industry itself, or from teams with riders who have massively benefited from us saving their riders' lives and looking after them? It's just a thought that crossed my mind when you were talking about it, if there's any leveraging of anything that could ever be done.
I think because we're a publicly funded health service that provides treatment free at the point of delivery, we would struggle to try and claim that money back from, say, insurers. We have made those inquiries, and that's, given that the way that we're set up is not possible. But I think there does need to be a system-wide rethink about how the money is funneled in, because obviously there's income for the government through licensing, sponsorship. There's the DT Plus, which I mentioned, is a big income now for the government, and also there's the overall impact of the 55,000 people on the island, staying in hotels, meals, drinks, campsites. The whole
effectively goes.
That I do think that's something that we need to discuss. But as I say, we're not alone in having that challenge. We does affect the wider government in terms of.
It's about that kind of joint
approach.
Myself and Teresa will be, in the centre of being part of that group.
Thank you, Sheena.
Just put to that chair, it was just about the manning line, having taken the matrons onto the manning line, that's been really helpful with the public. The public have contacted us. We've now got a little QR code, a little app around contact the matron, and since the manning line and linked to that, we started to see people come to them directly, and they can actually sort some issues out there and then straight away, especially those that are inpatient or those that are out with our district nurses. So I just wanted to highlight that.
Great, good. And hopefully the success of those will encourage more colleagues to want to get involved. So that's great. Okay, thank you very much. So moving on to the operating plan and mandate, Sean, if we may.
Yes, thank you, Chair. I'm take the paper as read, I think, rather than talk to the detail of it. In principle, there has been a modicum of progress across the delivery of the operating plan and the mandate. But there are some, and you can see it in the document that's been kindly prepared for me, there are some significant risks around the progress that's been made. They unfortunately in the main link to the need to invest to make the changes to transform the services, and that investment is still under negotiation. But it's progressing, that negotiation is progressing. There have been some small good progress made around clinical validation. And so we have now seen a further specialty undertake both administrative and clinical validation, which has given us a really, really good result in respiratory medicine. And again, is demonstrating to other clinical services the importance of doing this. But we still have a long way to go. And again, that's demonstrated in the pack. And the service around patients who are non-weight bearing, the new pathways that are being developed for them will both help them in their re-ablement while supporting them in their early rehab, which I think is a really positive move for us as an organisation, and will enable us to get the best use of the facilities that we have in caring for what's a really difficult post-treatment period of time where somebody struggles to be able to mobilise or to get around, because simply that would cause further harm or damage to them during that period of time. Those are the sort of headlines, really. I'm happy to take any questions on the report.
Thank you. Any comments or questions? Teresa?
It's just a comment, really. So, we know that we're still waiting for the drawdown and the approval of the transformation funds, which sort of unlocks the delivery for a number of these really important pieces of work. We've had the assurance from the department that it's their priority to try and assist us with that. So, Minister and Interim Chief Officer both very committed to help get that across the line and get that funding released, because we know it's linked to also our ability to make some of the financial savings that we've committed to as well as the transformation improvements that we've got in the operating.
Thank you. Tim?
Yeah, just to follow up on that link, thank you very much, Sean. It's a very useful document. And it's good to see it's all in one place like this. Just to follow up on Teresa's question, what are the main things here that are going to trip us up in terms of our outturn, in terms of our finances, and in terms of the SIP? What are the things you think here are going to put pressure on coming in on budget at the end of the year? Thank you.
I think the three key areas that are likely to impact the most on the financial part of the organisation are going to be the continued high utilisation of hospital services where other services can provide that. And so that inability to grow what we've already started within intermediate care, which has been a tremendous success, but to grow that and to grow primary care and community services, to be able to effect larger the prevention agenda, and also to enable them to look after chronic illness in the right way. I think for me that's probably one of the biggest impacts. I think there is no doubt a challenge around our workforce and people. So whilst we're doing a great job in terms of recruitment, we have some significant recruitment gaps in our medical workforce. We're still significantly struggling to recruit in our medical workforce. And alongside that, the benefits identified through job planning will be, as they would be in any environment, traditionally difficult to deliver, and they will be difficult to deliver. And again, that's a specific in the operating plan for this year. And the third thing, I think, is really front door. That's the best way I can describe it, Tim. But what I mean by that is ensuring that our older people get the right assessment in the right time and then the right care continuously, alongside the development around a more responsive acute and urgent care service. So when you really need help, you get it, but its intervention is not in a very traditional way. So it's not being admitted to a ward with multiple diagnostics and then a plan to get you home again. It's a much shorter intervention, which will get you home much quicker, reduces your dependency on health services and supports your family more. Getting those in place will take a lot longer than we had anticipated at the beginning of, or the end of last year when we were planning this year's programme, as we had expected the transformation funding around primary care at scale home first. And you've heard the therapists talk today about some of the wonderful things that they've been able to do that didn't require that further investment to make happen. But the things that now are needed require investment to enable them to happen, either to release people to do the work or to enable the service to double run, for want of a better term, so that actually you can do the transformation whilst running the existing service, because you can't leave people with an unsafe service. I think those are the three things that I would say.
Tim, you're on mute.
I was hoping that there was some lip reading. Just thank you. That was all. Just to say thank you.
Any other comments or questions? Okay, thank you, Sean. We now come on to the committee chairs' exception reports. Who is going to talk to the D&I committee?
Sorry, Sarah, we didn't have one in the reporting period, so that's an error on the agenda.
Okay. No problem. Tim, QSE, please.
I don't know whether people have seen the papers. I'm told they are on the website. They may not be in your pack. But there's nothing for this board under Alert Advise, under Assure. There are three areas: the performance accountability reviews, board assurance framework, and the risk registers, and nothing further to report unless Sheila wants to add anything. Thank you.
Sheila does not. Thank you. FP&C, 2nd of July.
Yeah, thank you, Sarah. So under the alert, we have just the April management accounts and the forecast deficit, which Tammy will cover later in the meeting in her papers. To advise, there was an interim financial direction relating to procurement. The actual wording isn't available yet, but once that is, that will again be brought through FP&C. And the Assure is just the work that's ongoing with the governance review. Financial governance, just about the commissioned audits that were commissioned last year, the independent audits have been combined into one action plan and they're being tracked by FP&C. And finally, the partnership meetings with tertiary providers, they're all in the diary, they've started, and again, will be tracked by FP&C.
Thank you. Audit?
I'm taking this on behalf of Nigel because I've helped chair. So there are no items under the alert banner. To advise, the statement of internal control has been prepared by Manx and signed off by the chief executive. A formal paper is going to be brought to our committee in September to confirm the status of that. In terms of assurance, performance accountability reviews have commenced with each of the divisions, as have the check and challenge sessions. It's all part of that, checking in and challenging on accountability and performance delivery, specifically against KPIs. We're confident this will and is improving accountability across the divisions, and we are undertaking some work within the committee around outstanding audit actions and part of the reporting pack, and some of the audit actions that have been outstanding for a long time and an uncomfortable amount of time. We're just uncovering some very practical issues, so none of it is insurmountable. We just need to look at some of the systems for flagging audit actions to the owners and where that might be failing us slightly. In terms of risk management, the risk profile has remained stable across Manx Care, and the committee were looking forward to the new BAF reporting and the risk kind of profiling there as well. Apart from that, I have nothing to add.
Thank you.
It was just to sort of give the assurance that the executive team are now going to review all of the outstanding audit actions to help get those closed. I think some of them have been closed. I know they have been enacted, but it's just the evidence and the assurance that. So the executive are going to have a look at that and hopefully get that into the best position by the next meeting.
I think that's entirely appropriate. I can see the frustration in the committee when you know that things have been completed. It's the assurance, documented assurance that's letting us down, if you like, in terms of the actual audit outcome, shall we say, and the recommendations that are contained within the reports.
And it's really an important piece of assurance to our external stakeholders.
100%.
Thank you. And then I chair the People Committee on the 4th. And there are two items under alert. One is the ongoing issue of pay awards, and if there was a pay award of the suggested 2%, that would be incredibly challenging for us. Then, as mentioned actually with our colleagues from therapies, we've been really successful at recruiting people into substantive posts, which obviously shows an increase in our headcount, but also means a decrease in our cost base. So I wanted to alert the board that we are not suddenly going out and recruiting loads and loads more staff. We're actually converting people off the bank and off agency into our workforce, and therefore saving agency spend, which is one of our priorities. Under advise, Elan Bannon is going out for a replacement system, and the Office of HR have invited us to work with them on that, so that's just to note. And under assurance, the ED&I forum and the staff networks are being embedded within the organisation. And as previously mentioned, the Manx Care website is being developed with a view to launching in Q1 in 2026. Helen, have I missed anything?
No, those are the key things, I think, Sarah.
We're very ahead of time, and we're expecting Nick. Would it be appropriate to ask Helen to take her agenda item next?
If we could, please.
Yeah, Helen, are you able to do that? Sorry, I should have given you some sort of sign language warning.
No, it's not a problem at all, Sarah. It's my pleasure. So I'm bringing the board up to date with our activities around restructure, and there are three key areas that I wanted to discuss with colleagues this afternoon around recruitment, around clinical centre, Senate, and around augmentation of alignment of services in terms of matching the requirements of our operating plan. So if I go back and start with recruitment, we are now in the process of recruiting to the senior clinical leadership roles that were defined in the restructure. So they are the divisional director roles in scheduled care, unscheduled care, and primary and community care divisions. Both scheduled care and unscheduled care recruitment activities have taken place for the divisional director. The offer is out and has been verbally accepted, so we're just going through the processes of agreeing contracts with the preferred candidate. We have also gone out for an interim divisional director of primary and community care. We've asked for expressions of interest within the organisation for a 6-month tenure, which will take us over the gap of the current incumbent retiring and give us the opportunity to do a substantive recruitment for that divisional director role. We anticipate that recruitment process will begin at the end of next week, and we would seek to have recruited somebody by the first week in September. At the same time, we are looking for divisional directors of nursing for those three divisions, and those open recs are due to go out this week. So we should start the recruitment process for them, and we hope to have the selection activities and selection process scheduled for the middle of next month. The next step after that is to go out for expressions of interest for clinical directors to lead the different delivery teams, and to put together some comms for colleagues so that they can understand exactly where we are with this process and the timelines associated with those elements. I think it's worth just pointing out, however, that we made, I think, the perfectly reasonable decision not to fare forward with the other roles until the divisional director role was in place, because clearly I think they have got a significant voice in those recruitment processes and should quite rightly be involved in the selection processes associated with those key roles. So the plan is that given notice periods and so on and so forth, we should have all of those senior divisional roles in place by the end of this year. Moving on to Clinical Senate, just to let colleagues know that obviously Clinical Senate was a key element of the restructure plans, and we have put forward proposals from the exec team which have been very positively received by our colleagues in the trade union side. BMA in particular have got involved very positively in this process, and are committed to co-creating the terms of reference and working model for the Clinical Senate. We are also now going out for workshops and engagement sessions with staff and stakeholders, so that all colleagues and service users can get involved in moulding what that Clinical Senate is going to look like and how it's going to work. Just as a side note, we have had quite a lot of feedback about the name Clinical Senate, but colleagues might be aware that I came from University of Manchester, where we had an academic senate. And although it was called Academic Senate, it included participation from all staff groups from the length and breadth of the organisation. So for me, the name of the thing doesn't tell you what its constituent parts are. So I'm mindful that we need to just unpick exactly what we mean by Clinical Senate, but from my experience at Manchester anyway, the Academic Senate was extremely effective and included a great many voices from colleagues that were not academic. So I'm certainly not too concerned about the name of it. I think if we get it working effectively and make sure that it is a broad church, that's the main thing for me. The third part is the work that we're doing with regards to the alignment of our services, and I'm delighted that therapies went first this morning, because that was a case study of how we are seeking to align our services to organisational operating plans, and to make sure that the advancement of patient-centred service provision is aligned with our patient-first, home-first strategies. So there is, and I think Sean already alluded to this, there is some more work that we need to do around transformation in workforce. That's not restructure, I would say. That's about making sure that we've got the right colleagues in the right places, working to the top of their registration with additional skill development, which I think is what the therapist team were talking about with regards to, for example, non-medical prescribing qualifications for practice-based therapists. I think that's everything that I wanted to cover. I'm mindful that we have got a communications plan to share the details of this with colleagues and stakeholders that I would hope will be ready to go this week. But otherwise, I think just open to questions.
Thanks, Helen. Any comments or questions for Helen? Nope. Oh, all right. Thank you so much. Thank you.
My pleasure.
What's my? Oh, is he here?
He is here, but
I was just going to suggest we took a 5-minute break. Not that I'm satisfying my own requirements. But if we come back at 2:20 and then invite Nick in, then is that okay? Yes. Thank you. She said, no, I can't do an American accent, but you know, about all this stuff in your media. Let me be this. Most things about me are completely fake. But the one thing that is not is my voice. Okay, is everybody back with us? I think we are all present and correct. Nick, thank you so much for joining us. Helen, Ashley, Tim, Bishop, and our new colleague, Obi, are online. And so once you've gone through your presentation, if they've got any comments or questions, I'll invite them to contribute. Do you want to say anything does anyone want to say anything by way of introduction or?
No, I think it's best just to hand over to Nick because we had been anticipating this report.
Yeah.
And I will second it because I think it was a really important report for Manx Care to commission. Worked really closely with Cordis Bright, and we have subsequently published the report in full with no redactions. And I think that in itself has been very much welcomed by those who have received and read the report and those who we've worked collaboratively with. So MenCat particularly were a key stakeholder in this. So, you know, there is a lot of work to do, but it's important that this board understands the importance of getting it right for the learning disability community and our services. So very much welcome the report as did the board, and I'll hand over to Nick.
Thanks, Sarah. So this presentation summarises what's in the covering report. I think it's worth you knowing that it's basically the same script as was used to brief colleagues, partners in the DHSC, ministers, MHAs, and also family members at 2 recent engagement meetings. So it seemed worth bringing this here. So the presentation looks at what prompted the report, some headlines from the report, and some key findings, what we're already doing, and what we still need to do in response to the report. And so the report was prompted because a range of concerns were escalated in August and September 2024. The summary of those concerns are that there were a number of registration and inspection reports. I should have said the report is specifically about 17 care homes run by the Adult Learning Disability Service, which is part of Manx Care. So those concerns, the registration and inspection reports related to, I think, 3 of the 17 homes Manx Care runs. There were some safeguarding concerns and casework at the time in response to a number of safeguarding alerts that also were also about people who received support in those services. There were also some internal management concerns about the impact of staffing restrictions at that time last year, which related more broadly to action that Manx Care took to protect the future employment of members of staff who needed to be redeployed because of the externalisation of React Bay. And there were also some other concerns being raised by other members of staff in the service. And so that's what you might call a cluster of concerns, a range of concerns from different sources. And so we did a bit of triangulation. We talked to a few people, we investigated the concerns. The safeguarding team, who directly report to me, escalated the concerns to me because they felt there was more than just a few safeguarding concerns about some individuals. They felt there were some systemic issues here. It's obviously important to acknowledge that I work for Manx Care, the adult safeguarding team work for Manx Care, as well as the service being provided by Manx Care. So before we decided what to do, we did talk to the independent chair of the Safeguarding Board on the Isle of Man and also the head of registration and inspection. We presented what we felt was a summary of information we'd gathered, and we talked to them about the proposal to get an independent pair of eyes to have a look at this service. And after that meeting, they deemed that it did seem like a proportionate response to commission this external review. So that's how it came about. So what is the report about? We asked Cordis Bright, who are experienced consultants, facilitators, and management consultants in this area, to look at the current delivery model, so how the service is provided, how those 17 pounds were provided, and to look at the associated quality assurance processes within that service. So how does that service check on itself in terms of the quality of what it delivers? We also asked them to do a desktop review of the funding, outputs and benchmark costs of the services, just to look around the UK and find out how our service compared against various bits of data across the UK. We also asked them to think about future strategic options for the service and any immediate recommendations that arose from the work they were doing. That's the sort of thing you would say to any external organisation coming in to a care and support provider. If anything arises in the course of your work that requires immediate action to protect people from risk of harm, don't wait to produce the findings, talk to us immediately. So that's a catch-all regular criteria that we would put in any exercise of this sort. So what does the report tell us? Some of the headlines, and these are headlines, this is really a reductive bullet point list, but you'll have the opportunity to look at the report anyway in more detail. So there is a very limited variety of support and care on offer and accommodation options on the Isle of Man. I think it's worth noting that of the money we spend on the island, and we spend around £22.5 million a year delivering services to adults with a learning disability, all but £2.5 million of that £22.5 million, so £20 million, is spent on the island. And of that £20 million spent on the island, just over 3/4 are spent on one single model of care called registered care, so care home provision for around 95 adults with a learning disability. And I think when we talk about the limited variety of support, you can see we've got about 300 people we know about. There will be a much broader group of people who are on the edge of learning disabilities, who may have some additional support requirements or other needs associated with learning difficulties. But of the 300 we know about, 76% of the money we spend is spent on about a third of them. And you often find that when you look at the spread of spend, because people with very complex support requirements will take up a bigger proportion of the money. But that is, when compared to the other jurisdictions, a very limited range of support in terms of the way we spend our money. One of the problems we particularly have is around accommodation options. The housing options we have on the island, I think it's safe to say, are in urgent need of review and development. They restrict what we can do in terms of the model of support, but also in terms of how we can use our money wisely. So we haven't really developed those accommodation options for a long time on the island. The report also noted that there's no current system-wide strategy or commissioning plan. So a system-wide strategy, the last one was the 2020 to 2025 Isle of Man Learning Disability Strategy, with all the things you'd expect from a cross-cutting strategy, introductions from government ministers, and so on and so on. So it's a system-wide strategy. That ran out at the end of March this year, and in many ways, there isn't a lot of evidence that the recommendations in that strategy have been rigorously acted upon. There's also no commissioning plan. So a commissioning plan is slightly different. It's a tier down in the hierarchy of strategy. So a commissioning strategy would be, a learning disability strategy would be drawn up by public health, by the government, in partnership with organisations like Manx Care. A commissioning plan, I think, is the sort of thing we should have within Manx Care, because we already have a mandate to deliver sufficient services at the right standard of quality for adults with a learning disability. And we deployed £22.5 million to do that. We do it in two ways. We spend about half that money on Manx Care services and about half of that money on other providers, private providers, not-for-profit providers, and so on. And it's striking that we don't have a plan for how we're going to be doing that over the next 3 years. We don't need permission to make that plan. We really do need to get on with it quite quickly and make sure we know what we're doing and what we plan to do in the future. service providers, government, social workers, registration and inspection. This next bullet point is really making the point that going forward, there's no one partner can fix the improvements that are noted in the report. We have to work across the system to do this together. It's very much something that no one part of the system can do on their own. So it's very, very important. We will need to work together in the future. And in particular, one of the strong themes in the report, we need to do that in close collaboration and liaison with family members in particular. There is a need for development in the Manx Care Adult Learning Disability Service, and I think that's clear in the report. That was the focus of the report. I'll come to some of the things that have already happened about that in a moment. But I think it's clear the report shone a light on the fact that this is about a whole system issue. And it's not just the Manx Care provision, but it's also provision by other providers that we need to look at as well. There is a need for short-term action for some people who need better support. There are a small number of individuals whose quality of life needs changing quickly, and those were identified in the report. And we've been working on finding solutions for those people since the back end of the last calendar year. Since late autumn last year, we already started that work. One of the real problems we face is finding the right accommodation options for that small number of people. And whilst that work has started, I can say in key particular instances, that work is yet to be completed. Finally, the way services operate now do not always make best use of resources. I'll just take you back to one example, which I think is indicative. So if somebody currently has support requirements that can't be met by an existing vacancy in an existing service, which usually relates to somebody having complicated support requirements that aren't easily managed, we often find ourselves buying a completely new service in its own property with its own staff team. That does not enable us to make best use of resources. Very few people need to be on their own, isolated from other people. Some people do, but very few people do. If you do that for everybody who doesn't fit into the existing round holes that we can't get square pegs into, that's a very, very expensive way of spending your money, because you need a whole new service for one person. There's no shared use of background support or anything like that. It's very eye-wateringly expensive. What are we already doing? Action is being taken in relating to restricted practice for some people who need better services. And a new commissioning plan is being developed, and I'll come to dates shortly. Part of the action on restricted practice relates to new policies within the Adult Learning Disability Service itself. They've introduced their own policy on how to manage restricted practices. And the most important sentence for me in that policy is, it's our ultimate aim to minimise and reduce and get rid of these things, which is exactly the right place to be. There was a suggestion in the report that some of these practices have become normalised over time, in that kind of worst case of institutionalisation, where we get used to things that probably could and should be better. There's a lot of hard work going on in the Adult Learning Disability Service, I would have to say that. We have begun discussions with partners across the system relating to housing options. Very specifically, we met with housing commissioners from the local authorities on the island, the DHSC, the Department for Infrastructure, all of our main service providers. We had speakers who were parents of people with learning disabilities. A very moving presentation from a parent of an 8-year-old son who answered the question what she'd like to see in 10 years' time when he was ready to grow up, which really reminded us that we are talking about quality of life for human beings here, not shuffling housing options around on a spreadsheet. And I think it was very instructive for everybody there. But we've also spoken to families. We've had 2 engagement sessions with families about this report. We've met with politicians and government civil servants as well. What we still need to do is we need to make sure that commissioning plans we develop on the island, and obviously this one is about learning disabilities, but this does sit in a wider context of commissioning plans for services across social care. But we need to make sure that we come up with a plan that works for people on the Isle of Man, because we can't just lift and shift models and experiences from other jurisdictions to the Isle of Man. We have a very unique governance arrangement here, a very unique economy, very unique health and care system here, which we need to make sure we make the best use of in order to develop plans on the island. So I think that's really important. A first opportunity to begin to tweak how we buy services going forward happens at the end of September this year, when we're going to recommission several £1 million worth of services that are currently provided by an organisation called Autism Initiatives. Their contracts come to the end. It's a normal commissioning cycle. But we have given ourselves a few extra months to allow this report to land so we can try to begin to apply learning when we recommission those services. We do need to communicate with partners, staff, families, individuals about the report, and engagement has already started, as I've said. I think the first commissioning plan we produce in August will also talk about future milestones. We also need to think about what next. And there's still an unanswered question that arises from the Cordes Bright report in terms of their advice, which was to get somebody else to run that service other than Manx Care. I know at the moment in Manx Care, no decision around that has been made, and we need to do that through due process and make sure we examine not who provides a service, but first of all, what services we need provided and what level of quality. And then the question of who provides, I think, should be a secondary question, because once you've worked out what you want and what you need, then you can determine who's best placed to deliver the service. The work with partners and providers needs to continue, and this really needs not to be a flash in the pan or a short firework display. This needs to be sustained work that lasts for a long time, because I can honestly say this will take several years to get to a position which we can all be proud of. We need to work with families and communities to sustain work on developing new opportunities for people, and we need to be humble enough as service providers to understand we can provide a setting for somebody to live their lives, but living a fulfilling life depends on communities, families, friends, social support, employment, decent healthcare access for all citizens on the island, and so on. So I think we need to work very much outside of our boundaries as a service provider. And finally, and this is just to make the point, I think that all of us have some responsibility. I manage the adult social work service, and we need to make sure that I need to make sure the people I manage are part of that change going forward, because our history as a social work service hasn't always been as good as we need it to be. So we haven't consistently reviewed what people are getting to make sure that, to avoid having to get someone from England to tell us that we're actually not doing as well as we should be doing. We haven't had a commissioning strategy that's been the subject of rigorous monitoring and scrutiny by Manx Care and the organisation. So those are some of the things that we also need to do, and make sure that we spread the responsibility so that responsibility is taken care of in a sustainable fashion for making the change that's necessary. That's a summary.
Thank you. Thank you very much indeed. Any comments or questions? Chris and then Sheila.
Well, I just want to put on record first my thanks to Nick, really, because I think that's very considered. I think it's been very thought through. I think that engagement into getting to this point has been exactly what it should have been. And I think he's really done a really good job in drawing out what the opportunities are in how we now move this forward. So that's not an easy task. So I think we need to recognise that. And then just to agree to the point just at the end, we've got to be clear what it is that we want to do before we then go out and try to decide how we're going to commission it up.
Thank you. Sheila and then Tim.
Yeah, thanks, Nick. It's really helpful. I suppose listening to you, and I think it's very helpful when you say this isn't about just housing somebody, because that seems to be the main issue that people seem to talk about. And your second thing you said is we need to get on with it. I think there's something about the way we integrate our services. And I think this is an example, and there are other examples of how we strengthen that integration. So all the different professions as a starter for 10 are all on the page. And there's something, I welcome your view, there's something about, I think sometimes we work all in silos and we don't connect things up together for the person and the family that we're trying to look after. And just your thoughts around how can we do that better? What's your thoughts getting underneath it? How can we connect it up so it's truly integrated?
I think the world of learning disability services are full of heroes and tragedies. It's a really very sad bit of history of these services, but it takes a tragedy followed by a hero, often a family member, to make something happen in these services. And I think that's sometimes because it's a relatively small cohort of people who exist on the fringes of priorities that exercise a whole health and care system. And so I think one of the things we need to do is make sure that if we come up with a learning disability commissioning plan, that's a Manx care document. It's not a Nick Frick document or a kind of adult social work document I think that would be one really good thing. I think integration is a really fascinating idea as well. And I think I'm coming to ELC shortly to talk about access to healthcare services, which I think is another good opportunity to look at this from a different lens. But one of the interesting things about integration in the context of this particular type of service is, yes, of course, we need to integrate across health and care. And of course, different professional groups who have to do work inside those. But critically, integration in this context is about integrating outside of our service provider bubble. So it is with communities, it is with housing partners, it is with not-for-profit charities, it is with publicans and landlords and people who run newsagents and sports clubs and nightclubs and employers. That's the kind of integration we need for a learning disability plan to work. So I think that's a big challenge for a big service provider with big challenges that face it in relation to service provision, because that's where it has to be a system-wide priority. So I think we really need to make sure that we don't lose sight of that element of the need for integration as well.
Thank you. Thank you. Tim.
So firstly, to thank Nick very much for bringing this presentation and for all the work that he's done right from the start in this area. So to just say thank you for that. I think it's I've got a couple of detailed things, but the overarching thing I think is interesting for Manx Care because it's really a test of how integrated social care and adult social care is in what is predominantly a health organisation. Because the learning disability service shouldn't be looking after anybody. It's not a service that looks after people. It's not a service that is a doing to service. So the service has to be one which enables and facilitates and assists people in living their best life in that phrase. And I think that's what Cordish Bright outlined, but I think it's also a test for us as a predominantly health organisation, whether we can manage the tensions between the different service areas that we manage, because there are clearly some services that do look after people and provide personal care and medical care and nursing care, and then there are some services which are different. So that's perhaps a more sort of philosophical starting point. The other thing I'd like to applaud is the involvement of our customers and family carers in the work that we're doing. That's just so important, and particularly I'd like to highlight family carers who often get told by professionals different things at different times in their lives about what's best for their loved one, and I think it's really important that we include family carers in that. I think just to note, as Cordish Bright say, it's not necessarily about the money, it's how the money's used. And I think that's a really important thing to pick up. And also, as Nick has highlighted, picking up the learning from this for other services that we commission and provide. And I think it's really important that we learn lessons in terms of our commissioning. I think that people have heard me say over the years that I think that the commissioning within Manx Care, but also across the whole of the health and social care place, is not as mature as it could be. And therefore, I think that the commissioning and then the monitoring, contract monitoring, the feedback, etc., is something which this will hopefully help us develop further and learn from. Those are my comments, Chair. Thank you.
Thank you, Tim. Nick, do you want to come back on our new fast?
No, I don't think so. I think I would absolutely echo the point about commissioning. I think it's a big planning shaped hole in this process, really, and that there's something that we need to set up robust and sustainable governance for, I think.
Yeah. Obi, do you want to come in?
Just a question on commissioning. Is there a good choice of providers on island for these services?
I think that's such a good question. What we've got three main specialist providers on the island. So one is our own service, the Adult Learning Disability Service, and then there are two others, one called Praxis and one called Autism Initiatives. We also use a range of other providers to provide us with bits of service where we need extra services, and they tend to be non-specialist domiciliary care providers on the island. So I think quite clearly the range of choice we've got on the island is constrained by the nature of being an island jurisdiction. I think we're probably interested. I was talking to somebody on Jersey recently. I think we've perhaps got a slightly better range of choice than they have on Jersey, where they've got probably a slightly smaller number of major providers. But that's where having an Isle of Man solution is really critical. We can't run this like we would run a commissioning plan in Manchester, for example. Whereas if you don't like what you're getting in urban Manchester, you've got 7 or 8 opportunities, 3 or 4 miles away, a train ride away, where you can go and get options and so on. So we do have to build something on the Isle of Man that's sustainable on the Isle of Man. I think that's very important. Now, it does involve a lower range of choice of providers than would be the case in a non-island jurisdiction. I think though we've got a sustainable approach at the moment if we can find ways of tweaking that, sustaining that, and directing that for the future.
Thank you, Charlie.
Thank you very much. The paper's really clear, as are the recommendations. My question's about commissioning this new service is going to be all about, and you mentioned it, your forward planning. How good is the data and information at your fingertips, Nick, to really look at the demand, how that's changed over the years, and what your ability is to get your crystal ball out and predict into the future demands of the service? Because if you're going to be commissioning this now, it's the perfect opportunity, isn't it, for you to really have a look at that. And I would like to be able to have some assurance that you're well supported on the data, the information, the demographics, to really nail what is the need now, but what is going to be the need in, say, 3 to 5 years' time as well. And we know that it's quite difficult at the moment for us to do that. So if you give us some insights into how good is the data or the information you have at the moment, and what do you need, or what improvements will you need in order to make a really good commissioning decision?
So I mentioned earlier a number of about 300 people. That's a number of people who are known to adult social work. Of them, about 240 people actively receive a service, and a smaller number just get advice and guidance and then known to us. So we have information about every one of those 300 people. We have up-to-date assessments on a very good proportion of those people. So our data, and this tends to be the case, data is not the problem in terms of who those people are. I'm talking about now, I'll come back to future in a minute. Intelligence and analysis is the capacity issue. So working through, and not only have we got data, every provider who we commission to provide a service will have a provider support plan. They have daily progress notes on what happened for that person today, how it went, when they went to for a walk down the front in Douglas or whatever. The data is incredibly rich.
Good.
We've got good financial information, but we've got very poor financial information about unit costs. We've got budgets as a big provider. We haven't got budgets for what's the day rate for a residential service? What's the hourly rate for domiciliary care? So that's how you begin to benchmark value for money. And we can work that out, but it's a little bit of a faff for my Excel skills to do. So I don't think data is the issue. I think we have actually augmented the data we've got We now have a single spreadsheet which adds back up to 22.5 million and has got 300 rows of it. And the 300 rows are the 300 individuals we provide support to. And there are probably 35 columns which go through every single support provider and categorise every individual in terms of, yes, they get a bit of that and a bit of that and a bit of that, and it adds up to that on the far right-hand column, and at the bottom of the far right-hand column, it comes back to 22.5 million. So that's not bad. Our housing data, the data we've got on housing tells us we haven't maintained our housing. It's falling apart, not pretty far. Not all of it, but some of it is. So we know it's terrible. But turning that into an action plan that involves the right action plan is the capacity bit. That's the capacity bit. That's the bit that takes time. Change is difficult, but sometimes it's much more difficult than doing nothing. And I think that there is a gravity to the status quo, and I think that's what you need capacity for, is to get people in the rooms in the right way, in a way to take people forward. So I think there is a capacity issue. We do have, and have had since February, a bid into the Treasury Transformation Fund. If I can just make a slight shout. Apparently, everybody thinks it's a great idea, but there isn't quite yet a signature on the dotted line which enables us to spend that money, some of which is commissioning capacity to help accelerate some of our work. Yes, anything anybody can do to accelerate that process would be very greatly received. So I do think there's no shortage of data. The process of turning the data into intelligence and subsequently into commissioning plans, you'll see when the commissioning plan comes out in August, it will be a first iteration. It won't be all emailed out because we're working with existing capacity to make that commissioning plan. So basically people are doing stuff they didn't used to do on top of what they used to do. So that's the reality. The future stuff, particularly in terms of adults with a learning disability, is very interesting. Again, the system somewhere knows about everybody who's born with a lifelong condition shortly after they're born. Roughly, somewhere between 5 and 15 people a year arrive in adult social work who are people with learning disabilities with a degree of complexity that means they need a service providing and they need to be open to a social worker. Those aren't big numbers. There's really no excuse for not planning ahead for those people. You really do know 4, 5, 6, 10, 15 years ahead that those people are on the way. This year, I can honestly say I had a very, very uncomfortable meeting recently with a family of a young woman for whom it would have been entirely predictable the support requirements she had, who did not have that service ready when she became 18.
Yes.
And quite rightly, they were infuriated about what was going on, and quite rightly, I felt very ashamed about the situation that we presented to them. So that's what I would say about future. There is work being done, I would say, and people are really passionate about trying to get this right. But I cannot pretend that this year that is not a live issue. That is really an indefensible. It's really indefensible, I would say.
Well, thank you. It's assuring to hear. It's very clear that you've got your finger on the pulse. You know what's available to you, but importantly, you know where your pinch points are and where you're lacking capacity in order to make this commissioning piece happen really well. So thank you for that oversight and insight into what we need to support you with and what you're going to need if you're going to be going down in this direction. So thank you.
Thank you, Teresa, and then Sheila. Yeah, thanks, Nick. When you gave your presentation, you talked about restrictive practice. And I guess my question is, service leave, are you assured we've got the right governance around monitoring restrictive practice, or is there anything we need to do immediately to give greater assurance to the board that we are looking into all aspects and we've got the right reporting, monitoring and oversight of restricted practice?
So I'll start with something that we did in September and October last year. So very quickly, as we began to look at the issues that had arisen that I referred to at the beginning of the presentation, the safeguarding alerts, the registration and inspection reports, we did look specifically at a number of cases. And we didn't wait for Corley's Bright report to be released in May this year to do that. We started the work immediately, and we engaged our own internal health safeguarding team to do a piece of work for us on that. What I would say was that the action plan that arose from that in relation to some key individuals was really embraced by the Adult Learning Disability Service. It was a very comprehensive plan. It's part of the genesis for the new policies on restrictive practice. So I would say there's been a really intense period of learning within the service on these things. But in the second part of the question is the kind of assurance about where we are now. Do we have the monitoring processes? I think we've probably got work to do on that in terms of how we are reporting these things up the line. Because I think the fact that that restricted practice policy, it was the subject of engagement earlier this year with families, which is a massive leap forward, and all credit to the manager who did that in very difficult circumstances with a lot of very worried family members. But you have to understand that that's a new policy in a service that's existed in various forms for decades. So the development journey has literally only just begun. Some small steps have been taken. So I would say to the board, I think take some of the key headlines from this and then make sure you check in again at points in the future. I would really advise that. But I would also suggest that internally, we have to look at quality assurance that suits the service and that responds to the service. So we can't imagine we can set up homogenous quality assurance processes in such a wide-ranging organisation as Manx Care. So I think that starts with, and the most meaningful place is for those local managers, those middle managers, those frontline staff to understand what standards are, and for those middle managers, team managers, home managers and frontline staff to understand they will be monitored on the key things that mean something around restricted practice. And I think that would be the exam question to ask of the quality assurance processes within the organisation. And I think, honestly, I would say we have a way to go. And again, speaking from my own point of view in terms of social work, this time last year, there was not one policy and procedure in adult social work. So we've got a load of policies and procedures in place. We have a foundation for practice. That doesn't mean we have an all singing, all dancing social work service. And I think a very similar statement could be made about the Adult Learning Disability Service. So I think that assurance, it would be absolutely crazy for me to say I can give you complete assurance that the restricted practice processes. I can completely assure you that people are trying very hard to remedy. But some of those restricted practices continue, partly because of housing options and poor physical environments to deliver services in.
I think the board needs to help in that space as well. You know, the Housing and Communities Board, you know, that's those relationships which sit outside of Manx Care to keep these items very much. And I really liked your analogy about the community ownership. And I think we have incredibly engaged communities who really want to help and who will be able to be much more impactful in the lives of these individuals than what Manx Care will be. And we need to enable that. And I think that will happen. I genuinely have a huge amount of hope and optimism that happens in our communities already. But we need really engagement to support that to be developed in line with this plan.
And I think that from a leadership point of view, that degree of humility that accepts our limited role in actually giving people fulfilling lives and the kind of important role played by communities, families, friends, social support, that's the ticket, I think. So if we got that kind of statement to you, I think we're in good hands, really.
Thank you. Sheila and then Tim.
I'm going to challenge because I think we play a significant role for learning disabilities. And what you described in terms of where's the data, we know when the children are born. You know that from the health service. So whilst absolutely it should be community-led, we have a really significant part to play in our integration because I'm not just talking about health, I'm about connecting the health, the social care, the learning disabilities. When you think about learning disabilities and the mental health, the physical health, all of that has to come together as one, or else you haven't got a community service without us playing, I think, a really significant role. And as you described, the numbers aren't that big, and we can plan well ahead because we know when the neonatal baby is born. We know.
Yeah.
So I think there's something about that integration and that connecting up, and it absolutely is a community service. But we have a really significant role to play.
No, I wouldn't want to suggest any different. I think you're right to challenge if that's how it came across. But absolutely, Manx Care has an incredibly important part to play in setting that foundation from which people can launch themselves to live fulfilling lives.
Tim.
Yes, I don't need a response to this. Really, just to agree with Sheila. Firstly, in terms of that integration piece, we know we struggle with annual health checks. We know we struggle with dentistry. We know we struggle with optician services, etc. And given that we are the commissioner or the provider of all those, the people who we work with a learning disability ought to have really easy access to all those services. And that's something which we should be able to do, unlike other parts of the country, in England, where they can't do that in such a coordinated way. So I think that's really important. I just also wanted just to say we must think about restrictive practice in its broadest sense. And restrictive practice may well be somebody living in a property where there's no public transport and they can't leave. If they wish to, not under any section of the Mental Health Act, and not detained, but our practice makes it such that somebody isn't able to do what they want to do. So I think really important to think about restrictive practice in that wider sense, in somebody who wants to go down to the pub in the evening, but there's no key worker or there's nobody who can assist them in that kind of restrictive practice. I think is really important to consider. And I know that Nick picks up on that. Thank you very much, Chair.
I just have one comment there.
Yeah.
It's actually a bit of good news. It's around health checks, annual health checks. And when we started this, I made a lazy assumption that annual health checks weren't being monitored. And it was a lazy assumption because I'd just like to give credit to a really quiet hero called Sarah Hares, who's part of the IPCC team, who diligently has been monitoring annual health checks for adults with a learning disability on an ongoing basis for several years. And it turns out in 2023-4, so not the last financial year before, around 64% of adults with a learning disability did have an annual health check. We know that because Sarah kept doing her work, not because she was told to, because it was the right thing to do. And that actually, sadly, doesn't make us an outlier if you compare our performance with performance in England. It does mean 35% of people haven't had an annual health check, which we need to improve on. But I just would pay tribute. There are bits of the system where that work does go on, and it's those quiet heroes that makes the difference between nothing happening and something happening. Because I can guarantee, if that hadn't been on the regular list of auditing primary care delivery on the island, it would not be 64%, it would be a lot lower. And that's what good looks like. I think that's what vigour and sustainability looks like, I think. So it'd be nice to get some feedback back to Sarah.
Thank you. Thank you. We will. Yeah. I think what we've heard is we recognise there are issues. We've commissioned a report that's given us a lot of detail into those issues. And we know, and thank you for setting out so clearly. We know now what we need to do. I think where the board can help is in you coming back on a semi-regular basis, and I'll leave Teresa and colleagues to decide what that is, Nick, to provide assurance that those things that Manx Care can get on with, we're getting on with, that those things that we need support from other bits of government, we're getting support or not, and what the board needs to escalate into its board-to-board discussions for additional help and support. And I'm imagining that commissioning will be one of those that we will need to keep a very close eye on. I think some of the support that you've heard from colleagues is very well deserved. Thank you for mentioning Sarah's work to us. But I think also Sheila's challenge is a really important one, which is we know who these people are. you know, they're literally being born at the end of the corridor. And we have a responsibility as an integrated system to care for them. I think Tim's points about restricted practice, I hadn't even thought about that. I hadn't thought, because I don't need help in leaving my house or driving myself or walking, you know, to the supermarket or the pub or to see my friends. I don't need that help. But if I did need that help and I was living somewhere where I couldn't access that public transport, if I was able, or the key worker clocked off at 6 because I was deemed I could live safely at home, I'd actually want to go to the football match. So I think I really appreciated that, Tim. Thank you for reminding us it's broader than just what we might think of immediately around restrictive practice. But it's a really important piece of work, and, you know, we have a duty under the mandate, but we also have a moral obligation to look after people who are more vulnerable and need that additional help. So thank you for bringing it. I think the board would welcome those regular updates, providing whatever help where we need to get involved, but also offering that support to you and colleagues as you drive these things forward. Does that sound like a way forward, Nick, that you were expecting?
Very, very much appreciated. I think keep giving it oxygen, giving the issue oxygen, keeping it on the agenda. I think it's very important. I'm so sorry, there's one more thing I must say, is that often restrictive practices happen because staff want to keep people safe. And I think that just leads me to say something I always try and remember to say, is that this report makes the point, and Teresa makes the point in the forward to this report, that staff have done their best in often very difficult circumstances. And the vast majority of our frontline staff are doing their best to support people as best they can. So I think it's just very important to note that, I think.
Thank you. Thank you. And we'll make sure that's part of the minutes.
Thank you. Thank you very much.
Thank you.
Thank you.
Thanks for coming.
Thank you.
Is it me or is it getting very warm in here?
Always.
I was going to ask a question about Okay. Tammy, we're coming to you for your report, with support, I think, from OB as you've discussed, I hope, together. So we'll hand over to you. Thank you.
So we've got the month to May summary position in the pack. So in terms of key headlines, currently at month 2, we have an operational year-to-date position of a 1.2 million deficit, taking into account additional costs which we've currently got earmarked against contingency funding. That takes us to a 2 million deficit. In terms of a forecast, we're currently reporting to achieve the position, albeit there are a number of risks feeding into that, which are included in the report. So some of those risks are around the pay awards, which haven't been agreed yet. We've made certain assumptions in the accounts about what that might be, but they're not agreed yet and may be higher. Also around the CIP, which is affecting the year-to-date position. Some of the schemes we've got are phased to deliver later in the year, which is affecting the year-to-date position because we've got most of the budget is in 12s. So that's having an impact. Also around tertiary care, we've not, as at month 2, we've not had any data through for the current financial year, but that's in line with England's reporting. It's generally around 2 months behind. We have got a data set ready for month 3 reporting, which is the month 1 full position, full freeze position, and we've got month 2 May's flex position as well, so we'll be able to have a clearer picture for month 3 reporting. And just feeding into some of the areas we've discussed around motorsport, etc. We've got a number of areas which are feeding into the baseline position in terms of costs, which may not be applicable to meet the criteria for the contingency funding. In terms of CIP, we've got identified schemes of 11 million and 3.7 million to find for in terms of the position. We are working up some of those schemes and we'll have further update at September board around those, but for the forecast we are assuming the full delivery of the 14.6 million CIP. Also we are because we are seeing these costs coming through year to date, we are assuming we'll need full usage of the 10 million Treasury contingency fund. So that's just the summary headlines of the position. Happy to take any questions.
Thank you. Teresa, do you want to add anything? I think I would just, because we talked about it earlier, stress the importance of being able to access the transformation fund. It starts to unlock some of the key savings, which will ultimately allow us to deliver the cost improvement programme. As Tammy has alluded to, there are a number of statements and considerations and caveats we placed in our operating plan. So we're not deviating from the operating plan that we published in March, nor indeed the mandate. And as Tammy's outlined, there are some costs which do not seem to align with terms of reference. The contingency fund that do sit outside what we all agreed was the baseline budget for Manx Care, and those still require resolving in terms of how those costs get resolved and funded. No, I think, as I say, we know there are some risks, but the risks are all being monitored and attempts being made to mitigate the risks that we've got. And I think month 3, when we get the figures in, will be an incredibly important month where we're able to do a much firmer reconciliation of our year-to-date position. But really grateful for the work that Tammy has done so far, working with the teams, and obviously Obi, who's only been with us a week, but in that strategic financial improvement role across the system, working both with Manx Care, DHSC and Treasury. His assessment will be really, really important. And obviously by the time the board next meet in public, we're talking the beginning of September. So we've got obviously a couple of months to work that through and really understand what the position is at month 3 and month 4. So thank you.
Any comments or questions? Tim.
I think it would be amiss not to comment. Just to firstly thank Tammy for undertaking all this work and for overseeing the financial position. I think, again, not needing any response, but as we can all see from the finance report, SIP is an issue. As Teresa says, our next meeting in public will be in September, when we'll be 6 months in. And while the finance report will lag behind that, at 6 months, it's every saving you need to make has to be doubled, if my maths is right, to get a full year effect. So there is a little trepidation I have in terms of this. I know that Tammy will have an iron grip on spending, and as the report identifies, absolutely us not spending money on things which we have not agreed to spend money on, and being clear, if there is no money, it can't be spent. And I think that it is really important to have that kind of grip, which I'm sure she will and her colleagues will. So that's really my only intervention. Thank you, Chair.
Thank you, Tim. Yes, Sean.
Thanks, Sarah. Yeah, I think I need to say something at this point because it's really, really important. So I fully appreciate Tim's stand, and I absolutely get the importance of the money. But when I was your improvement director, I made a very clear statement about needing to take some big risk, all of us. And I did the same thing with Tynwald. We have to be clear. We have to deliver care for people on this island, and we cannot go into a position where we've committed to delivering care and we then stop delivering that care because we've got the money wrong. But at the same time, we have to get on with doing the things that enable us to release the cash. And so we're absolutely all aligned on the importance of this transformation money. But if I'm honest, I still cannot comprehend that when I left you in April, there was a commitment to deliver it. And here we are in June, and we still don't actually have an outcome. We are going to have to make some decisions to get on with that transformation work, because otherwise the pay bill at the end of the year will be crippling us, and we will be stopping, or potentially, should I say, for the public record, we will be potentially stopping elective or other planned care type activities to be able to close the books. And I will not stand for that. I'm sorry. My moral will not stand for it. We have to deliver this work. And so I do need the board's commitment to some of the operational transformations that will start happening now. Starting today with the fact that I have asked every care group to share their financial and activity plans with all of their clinical staff, and for them to understand what the expectation is from them. And moving forward, to understand the transformative activities that we have to do to make these changes. It's wrong to not deliver care for people on this island when they need it, but it's also wrong to deliver that care in the wrong way and waste money, waste public money in the wrong way. So I do support what Tim is saying, but we have got to be really strong, because otherwise we will just do as we've always done. Because as Tim has just alluded to, the months are ticking on, and that calculation that Tammy talks to me about every week just grows and grows and grows, and we then end up having to do more to try and save the same amount of money. So it really is important. Thank you.
Thank you. Any other thoughts or comments? I mean, you've just said what I was going to say at the end. So
sorry.
Say that now. No, thank you, because I think, the board has always said that there are really, really challenging decisions that we have to take and that we have to implement. And we've been saying it for a while. And I think now we need to do some of that stuff. Sheila, do you want to come in?
Yeah, and I think it links to the paper around the operating plan as well, that sometimes you have to double run to get the change you need, and that costs money, as we know. And if you don't double run, what will happen is your clinical and care leadership will revert back because it's safer for them to do it. So I think this is really, really significant, that we've got to do the double running in order to move from one place and transform into the other. And that is really a really good example of that is some of the frailty work and getting people out of hospital.
Yeah.
Yeah.
So can I suggest we probably have an opportunity, therefore, to crystallise overnight where we would want to have a different discussion in the board tomorrow about what we would want to say. Let's have a conversation with the board about proceeding with at risk, because they are so incredibly important both for healthcare delivery but also liberation of savings. And we obviously have the opportunity to discuss those in detail with the Department of Health and Social Care. So let's talk specifics in the private board session tomorrow about what we're seeking permission on. And so potentially by the end of tomorrow, we've made some agreements on what we're going to actually get moving on.
I think that's helpful and appropriate. Charlie.
Just very briefly, Chair, 'cause I'm conscious of time. We've heard about phasing of SIP being one of the issues since I started. I just would like to know if the SIP plans have been revised and rephased and brought into some realms of reality, because hearing what Sean's just said, you're not going to want any member of the workforce to be wasting their time going down rabbit holes of SIP projects that are quite frankly never ever going to land in this year. So for the sake of the entire workforce that are all being pushed to make these improvements, we must have a SIP that's clear. It must be phased accurately in order to allow every member of the workforce to be laser focused on what they actually can achieve and can deliver, because you're going to be wasting time, motion and energy on things that aren't actually going to land and happen. So, but we've been hearing about phasing of SIP being an issue for years. We need to try and get that, what we have to, get that correct. Has a rephasing of all of the SIPs taken place?
So I think, if I may, Tammy, I think Obi's got his hand up. So
Sorry, Obi.
No. I'm hoping in his 5 minutes in the building, with us, he might be able to answer that question.
Yeah, I'll give just a very. This is the work that I'm doing with Tammy and the team and Sean and everyone else, is to understand. We can identify where the risks are because the plans are quite clear. It's how they're phased and how they'll deliver. And this is the work. This is the assessment work that I'm now doing, with a view to seeing what we can accelerate, what we can recover, where there are risk, or they need to be revised, or mitigation schemes. And we've been doing quite a bit of that work from the first day I landed, because that's the first priority where we can go. Besides the SIPs, of course, we also know, as Tammy has already pointed out, a number of cost pressure risks. So we need to look at this in the round. SIP is certainly one part of it, but there are other cost pressures. I think we'll get through that very, very quickly. We have to, because we're still at the early part of the year. And I think we'll be in a much more robust view when we are probably another couple of weeks. And we'll have a much clearer view on exactly where we are.
Thank you. Tammy, do you want to add anything? Great. Okay, thank you very much. That brings us to the end of our meeting. Nobody gave me any other business. Do we have any questions from the public? No, we don't. So that concludes the meeting. We've got 7 minutes to go and get an ice cream. That's my recommendation. Thank you very much. Thank you.
Thank you, everybody.
Thanks for joining online, guys. Good to see you.
Nice to see you. Bye.
Thank you.
Yeah, before.